نعم دكتور. بسم الله الرحمن الرحيم. برعاية رئيس جامعة النهرين الأستاذ الدكتور الطبيب علي الشاوي، يقيم مركز الدنا العدلي للبحث والتدريب محاضرة علمية بعنوان COVID-19 Complications a Neuropsychological Perspective Part 2، يلقيها علينا الدكتورة معصومة رحيم من بريطانيا. والدكتورة معصومة رحيم هي طبيب اختصاص طب نفسي سريري، ولديها خبرة في العمل في مجال الصحة العقلية للبالغين والاحتياجات المعقدة وفي أماكن الطب الشرعي، ولديها اهتمام خاص بالعمل مع الاضطرابات التنفسية والإصابات الدماغ المكتسبة، وتعمل حاليا في وحدة إعادة التأهيل العصبي والإقليمية في لندن. وفي عام 2019 تم تعيين الدكتورة معصومة رحيم زائرا خاصا طبيبا لمحكمة الحماية ومكتب الوصي العام من قبل اللورد المستشار، ويتم استدعائها بانتظام لتقييم القدرات العقلية بناء على تعليمات المحكمة. وأيضا معنا من بريطانيا من النمسا الدكتور عبد الله حسين البغدادي، طبيب أبحاث مركز أبحاث السكري والغدد الصماء جامعة غراتس الطبية النمسا، وعضو الجمعية الأوروبية للغدد الصماء، وكذلك عضو الجمعية الأوروبية للدراسات السكري، وطبيب مشرف في برنامج جابر بن حيان في النجف الأشرف لمتابعة مرضى العزل المنزلي المصابين بفيروس كورونا 19 عن بعد، ومحاضر ضيف للمتطوعين من غير الأطباء لمتابعة المصابين المعزولين منزليا بالتنسيق مع بعض الجامعات العراقية. تفضل دكتور.
السلام عليكم جميعا، عظم الله أجركم. مرحبا بكم في هذا اللقاء. السلام عليكم everyone. In this session, part 2 of the psychological complications of COVID-19. In this session with Dr. Masuma, it's the second part. We'll talk about the assessment of the psychological complications. Dr. Masum will take us step by step for all type of assessment, depression, delirium, and other complications. To not take a lot of time, Dr. Masuma, please go ahead.
Assalamu alaikum, and many thanks for attending. Inshallah, today we will look at practical assessment tools to be used to obtain a differential diagnosis where there is a query about the clinical profile of patients who have had COVID-19. As we said on Friday, there are a number of potential complications for patients who have had possibly a hypoxic brain injury, who may be suffering PTSD from physical illness or ventilation, people who may be depressed following a period of illness, people who may be anxious or health anxious. And we also talked very briefly on Friday about the potential for delirium. And so inshallah today we will cover the features and assessment of delirium, of depression and anxiety, including suicide risk assessment. Inshallah, we will then go on to look at a screening assessment for PTSD. And then finally, we will look at a brief assessment of cognition. Because my Arabic is not good, I will have to share my screen using English assessment tools. But inshallah, at the end of the session, I will email Dr. Abdullah Arabic versions of all of these measures so that they can be shared with you and used in your clinical practice. If there are any questions throughout, please either put them in the chat or raise your hand, and I can answer them as we go along, inshallah. Otherwise, there will be time at the end for questions.
Yeah. Just small, speak comment. Inshallah, after each part of assessment, we'll have short open time for questions. If someone have to write it in the chat or to ask directly. And inshallah, as Dr. Masan said, in the end will be 15 minutes for question and answers. Please, Dr. Yeah.
So inshallah, we will start with delirium. This was one of the questions that came up on Friday, thinking about how we assess for delirium. And delirium is very, very common. It can affect up to 80% of people in hospital. And it usually occurs secondary to some kind of infection, but it can also occur as a result of complications excuse me, arising from intubation and ventilation. And delirium is often underdiagnosed. And because of the way it presents, people with delirium are sometimes assumed to be psychotic or to be extremely depressed. The key features of delirium is that it fluctuates frequently. And so a person may be entirely alert and aware in the morning, but as the day progresses, they may become much more fatigued and much more confused. And their behavior can also change quite significantly. So that's one of the main features of delirium, that it is acute, but it is highly variable, and the course fluctuates over a period of hours and days. It's different from a psychosis in that regard, where there may be more consistent disturbance. Delirium has a much more variable profile. What we often find in delirium is that people have severe attentional deficits. Their ability to engage in conversation is extremely compromised. They are often drowsy or agitated. They are often extremely confused. Often people will not know where they are. They may think they're at home, or they are on a plane, or they're in an airport. Often these explanations can sound quite delusional and quite psychotic. And so it's very, very important that we assess for delirium. As I said, delirium can be triggered by direct injury to the brain. It can be triggered by acute infections, by the side effects of certain drugs, by surgery, by stress, or by a combination of all those things. When we consider assessment, it's very, very important to ensure that medical factors are the first line. If someone has a urinary infection or chest infection or sepsis, we know that that is likely to affect their awareness, their arousal, their behavior, their agitation, and their cognition. So it's very, very important to ensure that blood and urine tests are conducted and that any abnormalities are treated. Severe delirium can look a little bit like dementia because people are so inattentive and so confused that it is hard to differentiate between the two. And because delirium is so much more common in older people, it becomes even more important that the correct diagnosis is reached to ensure that treatment is given appropriately. One of the slightly easier things about delirium is that it is actually relatively simple to assess and to diagnose, and that once you've diagnosed it, treatment can be given quite rapidly. So if we think about the specific means of assessing delirium, we need to look firstly at someone's arousal, whether they're sleepy, how fatigued they are, if you can rouse them during conversation. It's very important when you're assessing for delirium to try to assess someone when they're sitting upright, not when they're lying down. It's very, very important. It's very important to assess their thinking skills and cognition, but most specifically, attention. It's important to have an idea of when the onset was, to ensure that it was an acute onset and not a chronic deterioration. A chronic deterioration would suggest that there are other complicating factors aside from delirium. And then we need to assess for any additional factors. So in respect of arousal, we're thinking about someone's level of consciousness. And really, we're looking at whether they respond to voice and conversation, whether they respond to touch or to pain, or whether they're unresponsive. We're also looking for features like eye opening when you speak to them, eye contact, whether they move in a specific way when instructed, and their posture. As I said, it's very important to assess someone sitting up. If they're not able to sit upright, that suggests that their arousal is reduced. When we think about assessing cognition, as I said, it's attention that we are really looking at. And that can be assessed in a number of ways. So if someone is able to engage in even a little bit of conversation, it's important to look out for whether they are distractible and whether they lose track of the conversation, or whether they start talking about different topics. These are the behavioral components to look out for. In respect of some kind of slightly more formal cognitive assessment, one of the best tests is to ask patients to name the months of the year in reverse order, to name them backwards. And that demonstrates whether they have enough mental attention to be able to do that. If they can't do that, it's worth asking them if they're able to say the days of the week backwards in reverse order. These are the most useful and the briefest tests. In respect of looking at the onset of the potential delirium, that will require looking through the medical notes and getting feedback from nursing staff or patients' relatives where possible, just to look at exactly when they began to get more confused. And that is the best source of information. It's also worth looking out for additional factors, such as changes in mood, and also looking out for changes in sleep-wake cycle. It's quite common for people with delirium to have disturbed sleep and be awake at night, and then be very, very tired and sleepy during the day. So once you have an idea of all those factors, you can put that picture together and you can get a differential diagnosis based upon arousal, acuteness of onset, attentional changes, and other behavioral and mood changes. Inshallah, I will send over a brief assessment of delirium, which only takes 2 or 3 minutes to administer. And inshallah, that will increase the extent to which clinicians are able to assess. Are there any questions on delirium specifically?
If I just ask one question, first question, when we think that a patient with delirium needs some rehabilitation or treatment, or to shift them to this psychiatrist?
Well, if someone appears to have delirium and the blood tests suggest that their inflammatory markers are up, the first one would be to attend to the cause of the delirium. And usually, once you administer whatever the first-line treatment is, antibiotics or so on, usually quite rapidly people's condition improves. It may take around a week and perhaps longer for someone to return to their usual level of cognition and function. Particularly in older people, people with additional health problems, and people who've been in hospital for quite some time, it can take longer for the delirium to resolve. But it would be important to ensure that the treatment is administered rapidly and the person is monitored, and that if once the course of treatment has finished, there are still difficulties, it may be worth referring to psychiatry. It will also be very important to make sure that the person has adequate hydration and nutrition, because dehydration can often occur and can worsen the delirium.
The problem we see sometimes post-COVID, like patients show some good prognosis with like the COVID infection, but they start to develop the delirium. Indeed, we can't add more because we see from the medical side the prognosis is good, but just that as secondary complications. Here we have just to wait, yes, we think, or there is something for rehabilitation we can add, especially in Iraq when there is no rehabilitation centers and not easy to access for a psychologist or a psychiatrist.
I think the very challenging thing is that if someone is not medically stable, it's very difficult to provide any other kind of treatment or rehabilitation. And so that has to be the priority, really, the organic or medical causes. It is difficult if there are not enough specialists available to provide a clinical opinion. But in the first instance, treating any acute medical condition must be prioritized.
Yeah. Also a question from Iman, that does delirium only affect elderly or all age groups?
It can affect all age groups. It's particularly common in older people, but it can affect anyone who has been in hospital and who has had surgery, for example. That's a very common cause. It can affect anyone, but it is particularly important to look out for it in older people because it is often confused with dementia and so treated inappropriately.
Yeah, okay. I think no further questions, so maybe we'll proceed further. Or, yeah.
I wonder if you could possibly share your screen for the depression and anxiety measure I sent you. Thank you.
So, yeah.
So one of the things that we talked about on Friday is that depression and anxiety are extremely common in people who have been hospitalized and people who have sustained some kind of brain injury. And so when we talk about COVID-19, we're often talking about people who have been deprived of oxygen because of the effect on the respiratory system, and who may have sustained some kind of hypoxic brain injury. But we're also talking about people who may have been separated from their family for some period of time. We're talking about people who have been extremely physically ill and who may be very, very frightened of becoming ill again, or frightened that they will not recover. And so it's very important to differentiate between mood disorders like depression and anxiety and cognition and trauma. And so inshallah, we'll start by looking at depression and anxiety. There are two very brief measures which help us to look at depression and anxiety as separate items. This screen is a 7-item questionnaire which allows you to ask a patient about the symptoms of anxiety. And so as you can see, this screen talks about feeling anxious or nervous. It asks whether the patient has been worrying in a way that they cannot stop or control. It asks whether they're worrying about lots of different things. It asks whether they have difficulty relaxing. It asks about whether they are restless and almost a bit agitated. It asks about changes in mood, because people who are anxious or stressed can often become very irritable or annoyed. And it asks about fear of the future, And so these are some of the most common symptoms of anxiety. And they are a mixture of physical symptoms, but also emotional and cognitive symptoms. So it taps into symptoms around thinking, around feeling, but also about changes in the body. And then it asks the patient what impact these symptoms are having. Because when we talk about mood disorders, we need to also have consideration of the impact of these changes on someone's day-to-day life. So if someone is worrying quite a lot, but it isn't interfering with their day-to-day life, perhaps it isn't a problem. But if they're worrying and that worry is stopping them from sleeping, and it means that they are very, very irritable all the time because they're so busy worrying, and if it means that they are not able to do things in their day-to-day life because they can't concentrate, that becomes more of a problem. And what we know about anxiety is that it affects our cognition. So if you are worrying to excess, it is very, very difficult for you to, for example, be able to concentrate on anything else. Anxiety takes up too much of the thinking space, and it means that other more complex thinking skills become harder. So it's very common, for example, for people who are very, very anxious or stressed to report that they can't remember things as well. And that is because the effect of anxiety on the neural networks and pathways within the brain is so significant that it can affect cognition. And so it's very important to assess for mood before you assess cognition as a pre-screen. So this is a 7-item scale, and the person simply answers whether this is never a problem, occasionally a problem, sometimes a problem, or very commonly a problem. And you give them a score, 0, 1, 2, or 3, and then you add up the score. And at the bottom of the measure, it tells you what the cutoffs are, whether someone meets the clinical threshold for depression, for anxiety. So it's a very quick assessment to use. Because it is quick, it is not comprehensive. It doesn't look at the different kinds of anxiety. It doesn't look at health anxiety or social anxiety or agoraphobia or obsessive compulsive thoughts. But for busy clinicians, it provides a rapid screening process to allow you to exclude anxiety as a potential diagnosis or consider it in the context of the other information you have. The second part of this tool is a 9-item assessment called the Patient Health Questionnaire. It's important to note that both of these questionnaires are based very much on the DSM and the diagnostic classifications of depression and anxiety. And so they are linked very clearly with what DSM requires as the criteria for depression or anxiety. When we look at the depression questions, again, there's 9 items and they're scored from 0 to 3. And the important thing is that in this case, we're asking patients how they've been feeling over the last 2 weeks. Because according to the diagnostic classification, symptoms must last 2 weeks. And when we're talking about depressive symptoms, we're really talking about feeling low in mood, about feeling hopeless, about a lack of enjoyment in life. But we're also talking about the biological symptoms, which are often related to sleep or appetite. And the tricky thing with depression is that some people who are depressed sleep very little and can't get to sleep, or have disturbed sleep, or wake early. And some people sleep too much and may spend half the day in bed. Some people, when they're depressed, have very little appetite and lose lots of weight. Some people, when they're depressed, eat a huge amount and may put on weight. And so, even though these questions are quite brief, it is perfectly possible, for example, when you ask question 3, to ask someone more specific details. And it's important to ask if they have trouble getting to sleep or trouble staying awake, because that will dictate your treatment. So some antidepressants, for example, have a sedating effect, medications like mirtazapine. But mirtazapine is also used for people who are depressed, whose appetite is very, very small. And it increases the appetite. And so it's often prescribed in that scenario. If someone is eating more than usual because they're depressed, you probably wouldn't want to prescribe mirtazapine because they will eat more and more. And of course, there are complications then. One of the most important questions on this assessment tool is question 9. The question about whether you would be better off dead or whether you are thinking of harming yourself. This is a crucial question to ask because although not everyone who is depressed will harm themselves, and although not everyone who harms themselves is depressed, it's very important to use this as the start of your risk assessment. If anyone answers 1, 2, or 3 on that question, suggesting that they have thoughts at least occasionally, I would always ask if they have any plan or intention to harm themselves. These are very important questions to ask. And sometimes clinicians are frightened of asking because they worry that if they ask someone how they would harm themselves, that may encourage the person to do so. Actually, the evidence is that asking a person how they would harm themselves does not increase their risk of self-harm or suicide. But what it does allow clinicians to do is to see how safe the person is and to put plans in place to ensure their safety. So I always ask my patients if they have any plan to harm themselves. Many people say no, and many people say that even if they didn't want to be alive anymore, they don't know how they would end their life. Many people do not know how to kill themselves, which is surprising when you work in medicine sometimes, because people who work in medicine know that there are lots of ways to harm yourself. But I always ask about plans. Do people have access to lots of medicines to be able to take an overdose? Have they had any thoughts of hanging themselves, for example? It's also important to ask about intention. If someone does not have a plan to harm themselves and doesn't know how they would do it, and if they do not have any intention, they are probably quite low risk for suicide. If someone has a plan but no intention, they are probably a moderate risk. And it's important then to make sure that they don't have access to lots of medicines, for example. It's important then that their family are involved to try to make the person safe. If someone has a plan, they know how they would hurt themselves, and they have the intention, they are much higher risk. And then the medical team needs to work together with the person and their family to see how they can reduce that risk. In my experience, lots of people who have been very physically ill have thoughts that they would be better off dead, but very few, as a proportion, have plans or intentions. And although medical teams can sometimes worry about asking these questions, they're very, very important questions to ask to make sure that our patients are safe. Again, at the bottom of this document, there are scoring criteria, and they indicate whether someone has mild, moderate, or severe levels of depression, which then allow you to think about what sort of treatment might be helpful in this scenario. Are there any questions on assessing depression or anxiety?
Well, I will start with the question. One question said about depression when it became just for a transit period. For example, with bad news, carrying patient receive news that he or she positive for COVID, they may feel one of those symptoms for 1 or 2 days. Should we worry about this? Should we do some assessment or any management for this, or we should usually wait? If it's longer time, then we can do something. This is one. Then later I will ask about the risk assessment. Yeah.
So I think it's very important to remember that everyone worries about stressful things, and everyone has short episodes where they feel sad or upset when they have had bad news. So, for example, if someone has had a bereavement in the family, if someone very close to them has died, we would expect them to be very sad, very upset, very withdrawn, maybe to have appetite and sleep changes. But we would not consider that clinical depression. We would consider that to be a normal response to a very, very stressful and upsetting experience. And so it's important when these assessments are done to think about that context. What's going on in the family, whether there have been other stressful life events, and the natural, normal consequences of physical health problems. That's why the depression tools all ask for 2 weeks worth of symptoms. But as I said, when there has been a major life event, like a divorce or a bereavement, you wouldn't treat someone for depression unless their symptoms had been going on for longer than 6 to 12 months, because you have to take account of what's going on in their life more generally.
I have a question here from Iman. How do we address the anxiety, and how can we improve their mood and help them relax and relieve them of the fear and worry they carry? How can we help them feel more confident and have more trust in themselves and with others as well?
So those are some very good questions. They're also questions which I think require quite long answers. And they are probably questions which could do with their own entire webinar session. I think the first step is to always conduct the assessment and to then make sure you have the conversation with the patient to try to establish exactly what the root worries are. So if it turns out that a patient is worried that because of COVID, they can no longer work, and that means there are money worries, that is one very specific conversation to have with them and their family. But if it turns out that they are very, very frightened that they will stop breathing because they've had COVID, and that worry means they're having trouble getting to sleep, that's a very different clinical picture and requires a very different kind of intervention. And so in the second scenario, where the person's worries are based much more on physiology and physical symptoms, something like education, telling them that they will not just stop breathing and that it is safe to go to sleep, maybe one intervention. Helping them to do relaxation exercises in the evenings so that they are less physiologically aroused may mean that it is easier for them to go to sleep, for example. But the intervention must always match the specifics of the problem. And so the challenge with doing brief assessments is that you don't get necessarily the detail that would help to have those conversations. So it's important to combine these questions with more in-depth questions using your clinical skills.
Okay. One question about risk assessment for suicide thoughts. We had like a questionnaire for patients for their symptoms, and we add the last question from this 9 question about if they have any ideas for being dead or harming yourself. What we realized with over 1,000 patients answered this questionnaire, like 90% were women, and many of them, when we asked them, we talked about finishing or dealing with their medical symptoms. About this answer, their answer for this question, they said they had it for transit period, sometimes because of the pain, sometimes because of like transient worry, extreme worry that they couldn't stand, for example, for themselves or family members. Can be that like about the first question, that 90% of the answer from women's side, does it make that the women more risk, or just because they more tend to talk about it? And about that the transient period of these ideas, can it be something dangerous that can develop for more, or how to deal with it?
So in the first case, it's very common globally that women report feeling more likely, or women are more likely to report having thoughts of harming themselves. It's also globally the case that men are more likely to actually harm themselves. So I think that these differences are often the result of how men and women think and whether they feel able to ask for help or express distress or upset. So I think that it's very, very important to make sure that all patients are being asked these questions, and also to keep in mind that there are very, very frequently differences in responding between men and women. In terms of your second question, again, it's very common for people to have transient thoughts of harming themselves in specific situations. What I always ask in those situations is, out of 10, where 10 is the worst, how strongly do you have the urge to harm yourself? And if someone says 3, 4, 5, that's not a significant number. That sounds more like passing thoughts in a stressful situation. If someone says 8 or 9, I would ask much more specifically about how long those episodes last, exactly what the triggers are when they're most likely to have those thoughts. And I would also ask what stops them from harming themselves. People often say, I think of hurting myself, but I worry about what will happen to my children. Often families are a big protective factor. Often people wouldn't want to cause harm or upset to their families. And those are big protective factors as well. And so if people report transient thoughts of harming themselves, I would ask more in-depth questions.
Mhm. Okay. I think no more questions, so maybe we'll proceed for the next part. Yeah.
Okay, if you could put up the PTSD screen, please.
Is it this one or?
No, it's the second document I sent you.
Okay. Just have it here, sorry. It doesn't open from my side. And
Okay. Let me see if I can open it. Okay. I will try to share my screen, but let's see if it works or not. So when we're talking about PTSD, we are... This is one of the brief measures that we use. It's called the Impact of Events Scale. And this is a 22-item scale which looks at the specific thoughts and feelings and behaviors associated with PTSD. And this questionnaire asks people about symptoms they have had in the last 7 days. And so, as I said, I will send an Arabic version of this, but it's a fairly brief measure, as you will see. Just one page, 22 items. So it asks about the very common symptoms. And so if you think about the impact of a very, very severe physical illness, where you have difficulty breathing, and maybe you thought you were going to die, or where you had some kind of peripheral neuropathy, and you lost sensation in your arms and your legs, and maybe you fell, and you didn't understand why you were unable to walk, and perhaps you went into intensive care and you were ventilated. These are extremely stressful, traumatic experiences. And what we are finding is that there are lots of people who are having flashbacks, who are having nightmares, who are having disturbed sleep, and who are often finding themselves sometimes getting very upset or angry or irritable. What we're also finding is that particular reminders can make those symptoms worse. So, for example, hospitals are very stressful environments. They are noisy, the lights are often very bright, they can be very busy environments. So someone might be in intensive care, for example, and then step down to a general medical ward. But there might be specific noises from machinery or specific alarms that might go off, which might remind them of the earlier traumatic memories. Or it may be the case that specific medical examinations and investigations trigger memories of the earlier traumatic investigations. So people can be very, very frightened. When people are very frightened and very anxious, it's quite common that they try to avoid those memories. They try to push the memories away. And so here we're talking about question 8, for example, or question 11. So avoiding reminders, trying not to think about it. These are the very, very common factors. So again, this is a relatively brief scale, just 22 items, and you get different scores for different items. So people may have intrusive thoughts. They may behave in ways that means they avoid reminders. And they may have physical symptoms of hypervigilance. And this scale allows you to get an overall score. And then, if you want to, but I think it's unnecessary for your purposes, you can look at separate scores across the 3 subscales. But the important thing for use in Iraq would be to get a total score. And then there's a table at the bottom which indicates whether someone has the clinical symptoms in meeting that would meet a diagnosis of PTSD. And so it's possible to have likely PTSD, probable PTSD, or actually very, very severe symptoms which may impact someone's physical health. Because what we know is that prolonged and severe anxiety, and PTSD is an anxiety disorder, affects your sympathetic nervous system and your immune response. And so it's very, very important for patients with high scores to try to treat that. And so whether that is using medications or whether there are ways of having them seen by a psychiatrist for other interventions, the higher the score, the more necessary it is that someone gets treatment, because the consequences can be very, very severe.
Just fast comment for non-psychologists and psychiatrists, PTSD is post-traumatic stress disorder, yes?
Correct, yes.
Yeah.
Sorry, my apologies.
Yeah. Yeah.
And actually what we know is that for patients who have had COVID and who may have been extremely unwell, the trauma of that experience may allow other memories of previous trauma to surface. So, for example, I have a patient at the moment in my unit who had a stroke. And since his stroke, he has had a lot more memories coming to the front of his mind about his experience of being in the war in Congo and Rwanda. So memories from 20 or 30 years ago, which he has been suppressing for a long time, have come to the surface. And there is good evidence that trauma following physical health problems can allow older memories of previous trauma to become more of a problem. So this is a very important problem to screen for. Are there any questions on screening for trauma?
No, we don't have to...
Okay.
Yeah.
So we'll move on to the last part of the session, inshallah.
Mm-hmm.
And this is looking at cognition.
Mm-hmm.
This is a very useful screening tool to assess for cognition and thinking skills. And it is one that is very widely used. It's called the Addenbrooke's Cognitive Examination because it was developed at Addenbrooke's Hospital in Cambridge in the UK. And it looks at thinking skills across a range of in a range of ways. So it looks, for example, at attention and concentration. It assesses memory. It assesses language skills. It assesses visuospatial function. And it assesses slightly more complex skills that we call the executive functions, which refer to planning, problem solving, and complex thinking and reasoning skills. This tool, as you will see, every question gives you a score, and I will send over the Arabic version and Arabic scoring criteria. And that means that at the end of the assessment, it takes about 15 minutes to administer. It's very quick.
Mm-hmm.
At the end of the assessment, you get a total score out of 100, but you also get separate scores for attention, memory, verbal fluency, which is your ability to generate words, for language, and for visual function. The cutoffs for this scale, if you score less than 88, you are assessed as having some kind of mild cognitive impairment. If you score less than 82, you probably have quite severe cognitive impairment or dementia.
Mm-hmm.
So this is a very, very useful tool. It has good validity, good sensitivity, and good specificity. For the patients we're talking about who've had COVID, who may have hypoxic brain injuries, we would expect changes in all of these domains: attention, memory, fluency, language, and visuospatial. But we would expect particular changes in attention and fluency. Those are the domains most closely associated with this kind of impairment. But you would see that people have changes probably in 3 or 4 of these domains. And so, as you will see, there are all sorts of different questions. If we start, I will go through this only very, very quickly.
Mm-hmm.
But you ask the patient where they are in the first section. You ask if they know if they're in hospital or not, or if they think they're somewhere else. You ask them if they're oriented to time and day and year. And if people don't really know where they are, or what the year is, or they're very confused, it's worth making sure that the medical tests for delirium have been done and that delirium has been excluded. As we go through the assessment, you ask people to do some simple arithmetic, some mathematics. So you say to them, what's 100 take away 7? And then you continue asking them that. And that is looking at their concentration and their ability to do mental arithmetic and that kind of abstract thinking. You give them 3 words and ask them to repeat them 30 seconds later, which allows you to assess their memory. You ask them to name words beginning with particular letters, and then you ask them to name as many animals as they can in 1 minute. And that allows you to assess how quickly they are thinking, if they are processing normally, or if it's very slow and it's very hard for them to do this. This is not a difficult test to pass. So if people are failing, that suggests some reasonably significant changes in their thinking. As we come further down the assessment, you show them pictures and you ask them just to name the items. So you just ask them to say spoon, book, kangaroo, penguin. The pictures, I think, are slightly different on the Arabic version. And this shows you whether their language ability is as good as it should be. Then you ask them to read some words. It's very important to make sure they have their reading glasses with them if they need them. You give them a pencil and paper and you ask them to copy these two diagrams. And that shows you whether their motor function is okay and how they are processing visual material. That's very, very useful to know. You ask them to draw a clock. Clock drawing is one of the simplest tests of cognition. It's also one of the most helpful. So you ask them to draw a clock, to put the numbers in, and set the hands at 5:10. And so that way you're looking at their right hemisphere and left hemisphere visual function. On this test, you ask them to tell you how many dots they can see in each square, but without pointing. So they can't use their fingers. They have to just look and tell you. And here they are shown letters of the alphabet, which are not entirely clear. On the Arabic version, I believe the letters are La and Mim and Ha and Wow, but possibly. And you ask the person to identify what the letter is. And then at the very end, you ask them once again to remember some of the material you gave them at the start of the test. And so you're assessing their memory over the course of 15 minutes to see how much they're able to retain. So it's a very brief assessment. Most assessment of cognition is much, much longer. But it's a very useful and quite brief tool to use. And it allows you to assess how much cognitive change there has been as a result of a possible hypoxic brain injury.
There's question time or?
Yes, please, yes.
Yeah. So the first question, who can apply this? Should be just the specialist or can be together, for example, with using now telemedicine, I can, for example, send it for the family member of the patients and they carry it with their patients. Is that possible or should be directly by like trained psychologist or at least physician? What do you think?
It should be carried out by a clinician. Mm-hmm. And the reason I say that is because when you do an assessment of someone's cognition, you're not just looking at the score, you're looking at how they approach the test. Mm-hmm. So when I send you the scoring criteria, you will see that, for example, on clock drawing, the way the person draws the clock, the way they place the numbers, and the way they draw the hands is important to notice. It's also important to notice whether they need reminding of the instructions because they haven't remembered. The difficulty is if you allow a family member to conduct the assessment, that will compromise the results. Yeah. Because family members are often very, very helpful.
Yeah. Can we say it is also possible to carry it with video call? Because we are in a situation, not always that it's possible to invite the patient for the clinic or to join the hospital, for example, examination. So, for example, to send it the family member, then I will join by video call to monitor that how it done and also to evaluate how it done. Or how much will be trusted when we do it in that way?
So it is. So the ideal scenario is you do it face to face in your clinic with no distractions, and it's just one-on-one. In real life, that isn't always possible, and so it is possible to do it via video call, but perhaps you would have to leave out certain items like the drawing items. It is possible but not ideal to give a family member a copy. The difficulty is you can't guarantee that they haven't shown the person in advance or they haven't helped them with the answers. So if I were to do it via video call, I would administer it myself and just apply the attention, memory, and language tests, and maybe avoid the other ones.
If there's any question. I think no. Yeah. A patient had COVID and now has an anxiety in relation to everything that has to do with testing and with COVID itself. So she now want to travel, and with the restriction, she is too scared to retake the test in this a result of PTSD from COVID. Is it like a result of PTSD? Like when patients have like phobia for everything related to COVID, post-infection, of course.
So the things to look out for in PTSD specifically are things like flashbacks of traumatic events, where memories pop into your mind, are very, very strong memories that make you extremely upset and agitated. That is quite different from a less severe anxiety. And so it would be very important to try to assess whether she's experiencing PTSD symptoms. Because many people will have a sort of low-level anxiety. Less people will have PTSD. And so it's worth trying to differentiate between the two.
Mm-hmm.
And so actually doing that 7-item anxiety questionnaire and the 22-item PTSD questionnaire may help to give you an answer.
Yeah, inshallah. Also, I would like to remind the colleagues, if they want to receive the assessments PDFs, they should register in the link we already shared in the chat, so we can later send them the assessments. Yeah. If anyone have a question to write in chat or ask directly by raising hand, please. One question about treatment and rehabilitation. Maybe I will answer the question, the part of the treatment just in general, and the part of rehabilitation will be answered by Dr. Masuma. Well, because this session is not about the management in deep, because we need a psychologist or psychiatrist to prescribe some medications. But what I can say first as a prophylaxis is to decrease the prescribed medications for the needed one. We don't give anything if the patient don't need, especially steroids or indeed all medications. We saw many patients receive plenty of medications. This medication itself safe when used by the normal situation alone, but in combination with other medication, maybe become more toxic and become with more complications, especially the psychological complications. Also, maybe using vitamin B complex like neurobean, it by other studies show that it helped a lot by depression and other psychological complications. And also we think it can be maybe effective, and also it is safe to prescribe, as it is not real medications, vitamins, but of course better to ask the physician before prescribe it or take it. From the rehabilitation part, Dr. Masum, what you say? Yesterday we talked, but before yesterday, but what maybe you repeat or add something?
Well, I think that rehabilitating patients with complex problems is difficult, and it takes time. And we're talking about patients who have had physical ill health and may need physical rehabilitation, pulmonary rehabilitation, for example, but also patients who may be anxious or depressed, and on top of that, may have cognitive changes. And so rehabilitation is something that needs lots of input. A medical treating team, we need the patient to understand exactly why they are experiencing what they're experiencing. And we need their family to also have that understanding and to have an idea of what would help. And so we talked on Friday a little bit about fatigue and the tiredness that often comes from respiratory conditions or being in hospital for a long time and from hypoxic brain injuries, and how that can be managed by patients and families and medical teams working together. But rehab is complex and it takes time.
One question from Jafar, that COVID in personality disorders, any details? So it's a very general question.
Well, I think there's not a lot of evidence on that at the moment. But I suppose if we're talking about people who are already complex, who then have a very severe, very serious illness, we might expect an increase in symptoms that look psychiatric. We might expect people to behave in ways which are aggressive or risky or challenging. But I suppose, again, I would always go back to looking at those screening tools for depression, anxiety, PTSD, and cognition, because you need to know what the root cause of the change in behavior and mood is. And so even though people will present in more complex ways, knowing exactly how to target your treatment will be the most useful thing. But to do that, you need a very robust assessment.
Yeah, clear. If there are any further question, please, maybe in 2 or 3 minutes. If there's no question, we will end the session. Dr. Masuma, the take-home message, if you would like to say, or the last message.
I think that patients with COVID present real challenges to treating teams. And often there is not enough resource for the amount of need that these patients have. I think the most that we can do as clinicians is try to get an accurate differential diagnosis and give the patient and their family as much information as we are able to help them understand some of these changes. Because many of them, particularly in the case of hypoxia, will be long-term changes. And so I think one of the most important jobs we have is to have a clear understanding of the patient's clinical profile and make sure we communicate that to them and their family. And if we've done that, that's a big bit of the job.
Exactly. My last message, or what I hope that, as we know that in Iraq, in addition to the shortage in medical staff and medical centers, we have extreme shortage in the psychological and psychiatric care. We hope from one side that our universities give more opportunity to train more psychologists and psychiatrists, and also our colleagues as physicians, they train or learn more tools how to apply some psychological and psychiatric tools to assess patients. This sessions is like a pilot for such training. Inshallah, more training will come in the future. From our side, Dr. Masuma also confirmed earlier that she will be happy for more sessions, and also I hope from the universities and also from the colleagues to do more. Special thanks for Dr. Ali Ashawi, professor of and the director of Nahrain University. From the DNA Forensic DNA Center, the director, assistant professor Dr. Dia Shamir, and also teaching Dr. Rasha Sadiq, and teaching assistant Dania Mun'im. Special thanks for them and for our amazing psychiatrist, sorry, Dr. Masuma Rahim, for his amazing and valuable lecture, and also for our colleagues for attending the session. Thanks a lot, and see you inshallah in other sessions. في أمان الله.